The role of alveolar macrophages in lung cancer development. Introduction. From the graph, lung cancer is listed as one of the three most prevalent malignancies in Malaysia. Males have a risk ratio of 1 in 55, while females have a risk ratio of 1 in 135. Lung cancer patients have the lowest survival rates compared to other cancers. Alveolar macrophage. Alveolar macrophages are a type of white blood cell that can be found in the lung, specifically in the pulmonary alveoli and the intraveolar septum. Alveolar macrophages have two origins, which are monocyte-derived lung macrophages and tissue-resident lung macrophages. General functions of the alveolar macrophage are the first line of defense against invading respiratory pathogens, regulate local inflammatory reaction, and also regulate adaptive immune response.
So next, we look at alveolar macrophage polarization and tumor progression. So basically, what is plasticity? So, macrophage known as outstanding plastic cell that can shift from one phenotype to another by change depends to environmental cues. Plasticity is considered central to their ability to switch from basal state in which they perform tissue-specific hemostatic function to an inflammatory state. The concept of cell plasticity originated from ability of stem cell to differentiate into multiple cell type. In response to environmental cue, such as in this case lung cancer, macrophage has an ability to undergo phenotypic and functional switch. Macrophage subset has a distinct inducer and different function. As we look here, macrophage polarized into M1 and M2 subset, which is M1 under influence of IFNY and LPS, and have anti-tumor function via secretion of INOS, interleukin-1, TNF, and IL-6. In contrast, M2 actually has three well-defined forms, which is M2A, M2B, and M2C. This M2 subtype is described as tumor promoter as they induce tumor growth through inhibition of efficient factor or overexpression of tumor progression factor such as interleukin-10, TGFB, and angiogenesis mediator. So we can look at the figure that shows simplest flow of M1 and M2, which is proof a dual role of alveolar macrophage in lung cancer progression, either for tumor resistant or tumor promotion. M2 associated with tumor initiation and progression, and as an inhibitor of inflammatory response and adaptive Th1 immunity. And also, M2 can simultaneously reduce INOS and arginine as pathogen killing, and can inhibit antigen presentation and T-cell proliferation, and as a vital role in promoting angiogenesis via VEGF.
This is the potential role of alveolar macrophages in tumor regression. So, pro-inflammatory cytokines, first is IL-1, which is involved in cytotoxicity and tumor growth suppression. Then we have IL-6, which by levels in bile cell cultures and blood from patients with lung cancer were significantly higher than benign cases. Alveolar macrophages from lung cancer patients enhanced IL-6 production in response to LPS stimulation, and IL-6 levels in bile fluid were greater compared to controls and even higher during radiotherapy. Finally is TNF-alpha, which prevents tumor growth by inhibiting angiogenesis, which is anti-tumor monokine, and is responsible for the cytotoxic effects of alveolar macrophages that occur spontaneously without external stimulation. And finally, alveolar macrophages from patients with lung cancer secreted more TNF-alpha and IL-1 after stimulation with IFN-gamma and granulocyte macrophage colony stimulating factor.
The role of anti-inflammatory cytokines TGF-beta and IL-10. Alveolar macrophages, it will exert pro-tumor effects via secretion of anti-inflammatory immunosuppressive cytokines. And TCG-beta will enhance tumor cell proliferation in vitro and also in vivo. IL-10 is a potent tumor angiogenesis inhibitor which is released by alveolar macrophages with or without LPS stimulation in vitro, and it inhibits the anti-tumor activities of alveolar macrophages, which may contribute to the tumor progression.
Altered alveolar macrophages function via inhibition of anti-tumor effect. It inhibits anti-tumor effect by secreting interleukin-10. When there is a high level of interleukin-10, it prevents immune-effected cells from activating pro-inflammatory cytokines. For example, it will inhibit the T-cell proliferation inducer interleukin-2. The function of interleukin-2 is to activate proliferation of lymphocytes with capacity to mediate tumor cytotoxicity. In addition, interleukin-2 also synthesis formation of TNF-A. Little to no interleukin-2 will result in reduction of TNF-A. TNF-A is a major regulator of inflammatory response, which will trigger the formation of cytokines, which help to boost anti-tumor activity by sending signals, and it also has a function to inhibit tumor regenesis. Without TNF-A, it will promote the proliferation and tumor growth.
Altered cytotoxicity and cytokine release. Altered cytotoxic alveolar macrophages of patients with lung cancer demonstrated both increased and decreased cytotoxic function. Altered cytotoxic activity in alveolar macrophages and tumor-associated macrophages, it has shown to mediated via decreased secretion of cytokines IL-1, IL-6, and TNF-alpha in patients with lung cancer. TNF-alpha, IL-1 and IL-6, it promotes the induction of Th1 cells, which consequently will limit the cytotoxic potential of alveolar macrophages and TAMS. IL-6 will release contribute to the anti-tumor function of alveolar macrophages. A pro-tumor function has also been proposed. IL-6 will inhibit the development of tumoricidal function in alveolar macrophages of lung cancer patients. Altered phagocytic capacity and receptor expression will activate T cells and stimulate phagocytosis, thus releasing pro-inflammatory cytokines TNF-alpha and IL-1. There are also underlying demographic and clinical characteristics that will affect, which is tumor history, underlying comorbidities, tumor stages, smoking status, and also age.
The role of angiogenesis in normal condition are to improve blood flow, suffocate tumor cell by reducing the blood flow and develop new pathway. Process of angiogenesis includes vasodilation, increased permeability, separation, migration, proliferation, remodeling, recruitment, and suppression. However, angiogenesis may also support tumor growth. This is due to the factors that was produced by tumor cell. Interleukin-8, VEGF family, PDGF family, and ECM enzyme are the major factors produced by tumor cell to induce angiogenesis.
Basically, smoking can give impact to alveolar macrophage functionality. In some studies, it showed that smoking can suppress anti-tumor activity of alveolar macrophage in smokers with lung cancer. It reduced the cytotoxicity level in alveolar macrophage from current smoking patient with lung cancer compared to non-smoker and ex-smoker. When the cytotoxicity is reduced, the macrophage cannot kill the tumor cell. This happens by affecting LPS and interferon gamma. Generally, cigarettes contain 7,357 chemical compounds and 70 of them are carcinogenic. And one of them is an NK, which will downregulate cytokine production by alveolar macrophage. It will inhibit TNF and interleukins-12 while increasing interleukin-10 and PGD2 release. Interleukin-10 will inhibit the production of TNF-alpha, but it will induce macrophage of M2 phenotype. M2 macrophage is an anti-inflammatory and associated in tumor formation and progression. Besides that, smoking will also decrease alveolar macrophage phagocytic ability in both current smoker and ex-smoker. When phagocytic being altered, cancer cell cannot be phagocyted by alveolar macrophage. Furthermore, cigarette smoke will also induce alveolar macrophage polarization towards M2 phenotype by inhibiting M1-related genes including CXCL9, CXCL10, CXCL11, and CCL5, and promoting M2-related genes such as MMP2 and MMP7. MMP2 and MPP7 involved in cancer pathogenesis as it will alter one of the tumor microenvironment, which is the extracellular matrix. Besides that, smoking will also inhibit the signaling of interferon gamma in alveolar macrophage, which can lead to both infection and the development of cancer. Lastly, smoking will also decrease the secretion of TNF-alpha, hence compromising the alveolar macrophage functionality.
Role of reactive oxygen species and nitric oxide synthase. Function of ROS is maintain the cellular redox homeostasis, while NOS are involved in realization of vascular smooth muscle and killing pathogen in response to inflammatory. In this part, it shows a normal physiology of human immune system due to lung tissue damage. Inducible NOS is responsible in producing nitric oxide, which is NO, that will kill the pathogen invading the lung tissue. Persistent inhalation of the invading pathogens or toxic agents may result in overwhelming production of ROS and RNS, and finally will initiate the growth of malignant cells.
Conclusion. Paradoxically, alveolar macrophage appear to play a role in lung cancer. Although alveolar macrophage have been shown to have pro-tumor actions that lead to tumor advancement, they have also been clearly linked in suppressing tumor growth with a subsequent tumor regression. Further study must be done in order to fully understand the real role of the alveolar macrophage in lung cancer.